John. How are you today?
Fine, Kathy. How are you?
I'm doing well, thank you.
Yes.
Yeah, I'd like to welcome our viewers to our series on substance use treatment. Viewers, when you finish this series, you're going to have a better understanding of the benefits of a substance use medical model treatment program for substance use disorders. We're beginning this journey with 5 digital workshops, and we'll continue to add additional sessions as we go. We know that there's a lot to running a successful treatment program, and we can't stress enough how important it is to have everyone in your facility on the same page, hence these workshops. We recommend watching them with your staff or minimally holding discussions on these topics. Mindsets like how you and your team of professionals view addiction or what type of therapies to use in your facility have to be similar so that patients get a unified treatment program regardless of which therapist, family coordinator, or other staff member a patient comes in contact with. My name is Catherine Hentrick, and I am on staff at Addiction Treatment Strategies. ATS is located in Edwardsville, Illinois, just outside of St. Louis. Addiction Treatment Strategies is a 6-month intensive outpatient treatment program. We are a therapeutically based, medically assisted program which provides an extremely effective treatment program for our patients afflicted with substance use disorders. This digital workshop is going to be led by John Crum, and John is the founder of Addiction Treatment Strategies. John, can you take a moment, please, and just talk a little bit about how these workshops came to be?
Sure, Kathy. I think it was a collaborative relationship between Southern Illinois Health Foundation and SLU because they were aware that there was a proverbial dearth of information available in the rural areas. So they collaborated and got together and worked out a set of procedures whereby we could increase the awareness of what was going on with regards to the opiate epidemic. And we have a number of informational vignettes like this that we're going to disseminate information, as well as a bunch of other positive things we're doing. We're putting naloxone in the hands of providers and police officers. So we're increasing the awareness of what's going on with the opiate epidemic, and SIF is directly responsible for doing that.
Okay, great, thank you. So like you said, we're going to put on a myriad of workshops for everyone, but today's workshop specifically is going to give our viewers some insight into why so many people do not seek help for their substance use disorders. We're going to start, John, if you don't mind, with a short little YouTube clip that I found that just seems to really set the tone for what we're trying to communicate with this presentation. So give me just a minute to pull this up for everyone. I'm going to share my screen. And there we go. Okay. I'm going to stop sharing that screen, bring us back here. All right. So John, I thought that was pretty powerful. Did you?
Yes, I think so. I think it's rather unique, and the more you look at it, I think the creativity of the people who put that together with the various substances superimposed on the face of the young lady was excellent.
I thought so too. So what I'm going to ask our viewers to do right now is to just grab a piece of paper, or just even in their head, write down one word that you would use to describe someone with a substance use disorder. What would that one word be? And then I want you to think a little bit about what might impact or influence your choice of word. Is it your education? Is it that this is your field of study? It might even be a personal experience. But now let's talk a little bit about someone from the general public, somebody who may not be in a field similar to yours. What's one word that you think they might use to describe someone with a substance use disorder? And why might the general public use these words to describe someone with a mental illness? Is it their lack of knowledge? Could it be a negative personal experience? Is it a media portrayal? What might that be? And let's give you an example. Let's say that we have a gentleman who had a heart attack and he had stents put in. He was told to eat healthy, to exercise, to see his doctor regularly, but he didn't. We would all be appalled to hear someone say, well, he deserved it. He got what he needed. He knew what he needed to do, and he sure didn't do it. Sadly, however, this is quite often the narrative for those people with an addiction. John, can you talk a little bit about the DSM definition?
Yeah, DSM defines a substance use disorder involves a pattern of symptoms caused by using a substance that an individual continues to take despite its negative consequences. This is an offshoot of the AMA 1966 definition of a substance use disorder, in which the AMA described it as a chronic relapsing disease in which the structure and function of the brain has changed, characterized by cravings, compulsions, and continued use in spite of the consequences. So you can tell this is an abbreviated form of what the AMA was saying in 1966.
All right. So we know that a substance use disorder is an ugly illness, and unlike most other illnesses, substance use disorders are characterized predominantly, like John just said, by behavior. We see it in people. We see it in people who may harm themselves or others, who seemingly refuse to change their behavior, who may lie, steal, and cheat in order to obtain their drug of choice because their cravings are so intense, who may unknowingly hurt those that they love, who make decisions to continue to use in spite of the negative consequences, who may seem to be unmotivated, and whose behavior may cross into criminality. Now, there's one word that you may see all the way down here, and that is who may. Not all people who are afflicted with substance use disorders present the same way. But these are many characteristics and many things that the general public may see.
So, Kathy, when we're talking about that in terms of these characteristics, what in the formation of a stigma, what's happening is that people are lumping all those different significant individual diagnoses or behavior patterns, and they're throwing them all into a big salad, and then everybody gets a sense of stigmatized as a result of if someone uses a particular substance, then they're going to get all those negative perceptions or all those negative labels, and that's where the stigma comes from.
Right, right. So the public only sees the outside behavior, which is kind of sad because it's definitely not a great portrayal of what this disorder is all about. John, do you think that this is why this particular disease might be riddled with, as we hear so often, shame, guilt, humiliation?
Well, I think that's a great part of it in terms of those folks who don't seem to have or be afflicted with the addiction are quick to judge. And I think that's human characteristic, or that's human nature. If you're not like me and there's something wrong with you, I'm probably going to pick on you for some reason or another. And I think that's a characteristic of not being informed or being ignorant about what's happening. And it's, if you're not like me, then somehow or another, I'm going to figure out a way to ostracize you. I think that's a human characteristic, but I think it's particularly complicated when we're dealing with individuals who have a substance who in reality don't have the capacity to make all those changes that we would want them to make as quickly as we'd like to make them.
Sure. All right. So who's disseminating accurate information? If we know that we've got a lot of information that isn't real accurate. Today, it's possible for someone studying to become a medical doctor to attend 4 years of undergraduate study, 4 years of medical school, and even several years of residency, and never take a single course in addiction science. So the general public receives their information through media portrayals, personal experience, and what they read in their local news source. John, I know when you got your degree and you first started to study substance use disorders, what type of training did you have initially in addiction?
Not much in terms of, it was pretty much a moralistic approach, and we did pretty much the same thing even back in the 60s in terms of, obviously we were familiar with what AA was, and I was fortunate enough back then to attend an AA meeting to see what was happening, but we certainly didn't get any type of scientific approach to what could be occurring in terms of, we had the definitions, but it was pretty much predicated on a moralistic approach to addiction in the 60s for sure.
That's good. So what's the end result? As a society, we remain in a state of denial about the true nature of addiction. And there's been very little changes in societal perception of someone with a substance use disorder. And due to a lack of education and an understanding of the science behind addiction, people tend to develop their own stigma surrounding addiction and those afflicted by a substance use disorder. And John, I know you've been in the field for a long time. What shifts have you seen in perceptions?
How long's a long time, Kathy?
Pardon me?
You said I was in the field for a long time. How long's a long time?
Well, I'm not sure. How long would you say a long time is?
More than a week. Yeah, I think a lot of things have changed in terms of definitely from the 60s and the 70s and 80s. We have an increased awareness, but at the same time, as it relates specifically to the opioid epidemic, we're still losing over 115,000 people a year to the opioid epidemic. And from my personal bias perception, I don't know that the stigma significantly hasn't changed. I think it changes on an individual basis. I think it changes as a result of mental health professionals becoming more aware that what they can do, involving more families. I think one of the greatest changes that have been made in the last probably 4 or 5 years has been the involvement of police officers with substance abuse treatment programs. I think that's broken down a lot of barriers and certainly helped to, if you will, to get police officers aware of what's going on. I think what this program is doing is getting naloxone in the hands of police officers and other service providers. I think there's an awful lot of training and education that's going on regularly. But then you have to look at what's happened since 2017. The SAMHSA survey said in 2017 we had 19.7 million people who were addicted to substances at that time. And in 2023, 6 years later, we've got 46.3 million. That's more than doubled in a
Right.
very, very short period of time. So I hope that we continue to increase education, information, more collaborative relationships between everyone, and certainly more energy expended on the part of how do you get people into treatment.
Right. And we're going to throw a lot of numbers at you. But like you just said, John, I mean, these are huge numbers of people who are dying. Why do you think this has not rose to the state of a global pandemic?
Well, I think it is just because people don't recognize it. And I think until it impacts on you personally, people don't get emotionally attached to fixing the problem. It takes an awful lot of energy for a long period of time to bring about change. I think a number of people, we're talking 1 out of 3 people are aware of someone who's died as a result of an opiate epidemic. That's significant. However, to bring about change in the treatment modalities and the treatment intervention strategies is going to take an extended period of time. I think we're making progress. Obviously, not as quickly as we'd like to, given the large number of people that are dying as a result of this opiate epidemic.
Right. And this is what this slide more or less says. Are we going to change societal stigmas towards those with substance abuse disorder? Maybe, but then again, maybe not. But in the meantime, while we wait for people to change their views towards receiving therapies for this illness, people are dying at an alarming rate. And we're going to throw, like I said, a lot of numbers at you. But in the 12-month period ending April 30th, 2023, we had 111,400 people who passed away. That's at a rate of close to 305 deaths per day, which is really alarming.
Yeah, I think let's go back to that concept of what's really alarming is not so much the number of people that are passing away, but to me, it's the age of the people that are passing away. I mean, we're talking about people who are 12, 13, 14 years of age. They haven't even reached adolescent yet. And I think that's really significant, why we need to get into the schools and why we need to have more early intervention programs.
So, as we mention this and talk about it being a pandemic, it's not a funding issue, however. Last year, the United States spent $42.5 billion to improve outcomes for those with substance use disorders. But unfortunately, the majority of that funding went towards collaborations and conversations amongst professionals in the mental health, medical, and legal arenas. Now, we're not saying that that's not necessary. It's most definitely necessary. However, when you're looking at 42.5 billion, that's a lot of conversations taking place. And even with all those conversations, still 305 people per day died while professionals talked and trained and planned. 42.5 billion, not in its entirety, but close to it, could have been used to treat people. Now, of course, this includes more than just monies going straight to communities for direct service. John, where else might that money be funneled?
Well, I think a lot of it has to do, like we were talking about, prevention education. I certainly think that we need to address the concept in medical school. As you know, we had a young lady from here who served as a case manager for a couple of years, was sufficiently bright to go off to med school. And one of the things we were really interested in was how were they going to address the addiction issues for physicians. And when she got into that particular part of her medical training, she said the only thing that they discussed was the impact of alcohol and other substances on the organ systems of the brain. They didn't talk about the sociological phenomena of what happens to people, what we need to do to get more involved, even as physicians with mental health centers and substance abuse providers. They kept it specifically to medical intervention strategies. I think that part has to change because I think that's oftentimes where someone enters the system is through their physician.
Right. And I think what we're saying, we're not saying that we shouldn't be educating, by any means. But what we're saying is that while we are educating, we still need to be treating people, and we need to be treating people in large numbers. In 1952, the first edition of the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, DSM, which is what we all know it by, identified addiction as part of the sociopathic personality disturbance. So why are the number of people dying from substances increasing annually when we recognized addiction as a mental illness over 70 years ago? The answer is complicated, but stigma that accompanies this disease plays a major role. And I know, John, you've seen that firsthand, all the time. You're on councils, you're on public awareness groups, that require lots of resources and people's time. Is it frustrating to you at times?
Oh, very much so. In terms of, I think it's not just frustrating for me, it's frustrating for me and all the other people who are in a position to discuss the problem. We know the problem. That doesn't necessarily mean we have the solution. I think everybody who sits on the panels has a vested interest in improving what's going on. And you mentioned that in the DSM-1 in 1952 had substance abuse disorder as a sociopathic personality. It was still the same in the 1968 version, the DSM-2. It was a personality disorder. So that isn't, of course, back then that wasn't much of a change, but I think at least we're looking at it as a mental health condition where we have some intervention strategies. And I think from all of the panels I sat on, I think the one thing that we're in agreement with, we need more treatment providers where we have good, competent residential care.
Mm-hmm. So viewers, what I want you to do right now is just take your piece of paper and write down a few synonyms for stigma. What I see is criticizing, disapproving, deprecate. The real definition is a mark of disgrace associated with a particular circumstance, quality, or person, or a set of negative and unfair beliefs that a society or group of people have about something. Stigma is really when someone views you in a negative way because you have a distinguishing characteristic or a personal trait that's thought to be or actually is a disadvantage, kind of a negative stereotype, if you will. Unfortunately, negative attitudes and beliefs toward people who have a mental health condition are extremely common. So what we're asking everyone to do is to start this process of talking about addiction and normalizing those conversations. People with substance use disorders are not always afforded the same kind of ongoing care as others with chronic diseases. That stigma keeps many people from being diagnosed in the first place. It keeps them from getting appropriate treatment and maintaining that treatment, and keeps them from staying in recovery. So those discussions and normalizing those discussions can do nothing but help our situation. Do you think so, John?
Yeah, I think that's extremely appropriate. As you know, we have a number of people, in addition to their addiction, are treated for anxiety. I have some private patients that I treat for anxiety, and they believe that they're seriously mentally ill because they have anxiety. Well, it's relative to the standard by which we do a clinical assessment on someone. Someone who has anxiety certainly has a mental illness, but that doesn't make them psychotic. At the same time, I don't think the general public does not have a good understanding of the stigma that's associated with mental health as well as addiction, because they think there's a great deal of fear that continues to surround even talking about a mental illness, for fear that if I talk to you and you have a mental illness, I might get some of what it is that you have. And I think once they get into that dark rabbit hole, if you will, they're afraid they too might be afflicted with something, and that people, because they judge people, they know people will judge them. So I think that's a large part in why we need to talk normally about a mental health condition, or lots of mental health conditions, because we've come a long way from the 50s and 60s that we can have good treatment outcomes for all of these.
Mm-hmm. So what if you're watching this right now and you're not a healthcare provider and you don't really even know anyone afflicted with this disease? Why should you care? Why should you care about normalizing these conversations? Well, in 2017, 21.8 million people met the criteria for a substance use disorder. That's 8% of our adult population. In 2022, 46.3 million people aged 12 or older, or 16.5% of the population, met the applicable DSM-5 criteria for having a substance abuse disorder. 94% of people aged 12 or older with a substance use disorder did not receive any treatment. And to me, John, that's statement right there is just extremely alarming.
I think the number that's really significant when people look at that, to me, is that when you look at the parameter, probably 10, 15 years ago, we weren't talking about people 12 or older. We were
Yeah.
talking about people who are 18 or older. So now, because we're beginning to, thank goodness, recognize that children also have issues other than addiction, we're looking at how we can treat people in that younger age group, because it certainly impacts on the stigma of what's going on. It certainly impacts on the numbers. I think people should become aware that we're not talking about people who are 21 and older. We're talking about people who are 12 and older.
Right. Children. I mean,
Mhm.
literally children,
Babies.
pre-adolescents. Mhm.
Mhm.
A large percentage of you have indeed had contact with someone who's struggling with addiction, especially if you're in the field, of course, or minimally know a family member who is struggling. You know, those families may be working hard to hide their very personal struggles. So why should I care? You know, do we have an obligation as a community? You know, if we look at the COVID epidemic, you know, we all wore masks, you know, regardless of whether we had COVID or not. In relation to heart disease, you know, we all answer our doctor's questions about eating habits and exercise. So how do we begin to have discourse around the subject of substance use disorder treatment? So viewers, I'd like you to examine your own thinking. You know, how much do you talk about your thoughts about addiction? You know, what are your personal preconceived notions? What are your thoughts? What are your opinions? What have you shared already on your social media platforms in regards to how you view funding, policies, and how we address this epidemic? Are you vocal? Is this your passion? You know, let's see if we can look at this just a little bit differently. So John, can you talk about this just a little bit, please?
Which part, Kathy? You want me to go to the numbers in terms of?
Yeah, let's
Yeah, if we offered 10 people in the audience today 60 tablets of Percocets, statistically, 8 out of 10 of these people would take some of them and would feel nauseated, itchy, headachy. They'd throw them away and use Tylenol. Statistically, 2 of these 10 people might feel energy, feel less depressed, may ask for a refill. Okay. So then we have to ask that in terms of statistically, if we're stepping back and looking at these people, are the 2 people who took the pills and felt good, are they weak people? Do they have some type of a moral flaw? Do the 8 people have some type of moral superiority? That depends on what it is that you understand to be true. If we look at what's called conventional wisdom, which is where stigma comes from, it's what people believe to be true without statistics or data. Yeah, I would say those people who didn't take the pill are the ones who may be a component of stigmatizing the 2 people that did. So with regards to that, I think we have to look at what is the background and how do people develop an addiction, and that's, some of it is for sure genetic, in terms of it's greater than 60% is a genetic predisposition. That means if your mom and dad have some type of addiction or something that leads to addiction, the chances are increased significantly that you will have one. And indeed, then we also have the age of onset by which people start using a substance. And there are all kinds of things in there in terms of when people use substances. Did you start using at 12, 13, 14? Did you steal alcohol from your dad's liquor cabinet? Or did you go to school and first get exposed to marijuana? Or as you know, we've had people here who have been exposed to even fentanyl at the age in grade school, where they're like 12 and 13 years of age. So the
Right.
timing of the first exposure is extremely important as it goes to the health risks and what happens with regards to brain development. As some of us are aware, when we talk about brain development, years ago we thought that the brain developed fully by the time we were 16, and then we got into more and more examining of using better instruments that it probably wasn't 16, it wasn't then it became 18, then it became 21, then it was 24, 26, 28. And right now, we probably know that the brain isn't fully mature with regards to all of the myelinated sheaths being fully formed around your neurotransmitters until the age of 30. Well, I think that has a lot of implications for what happens to people when they start engaging in activities that are normal part of growth and development, but they're in the 2% that the brain reacted differently to that particular medication, the Percocets, if you will, and it did something positive for them because the brain is, if you will, is a positive reinforcement system. If it feels good, chances are you're going to do it again, whether you know it or not, especially in that age group. And that is the beginning of the development of an addiction. And at that point, you don't even know that you're developing an addiction. So it's a learned process, much like education. Your brain is learning, and then it becomes dependent on that substance, and then you begin to fall into the category of I have to continue using this medication, if you will, in order to function. And then all of a sudden, that's when you get into the stigmatization of now I'm a loser, now I'm this, now I'm this. People don't even know what it is that they did to get here until they enter treatment. And by then, they may be 8, 10, 12 years into a process of developing an addiction, and then they become some of those stigmatized people.
Mm-hmm. And, you know, the biggest risk probably is the stigma with diagnosing. You know, as we know, very few people are afraid to tell their doctors when they have a lump in their breast, or a concern about diabetes because they're overly tired or overly thirsty. But bringing up substance use, has typically been a don't ask, don't tell topic. So let's use an example here. You have a teen pregnant mother, who fills out a medical questionnaire asking if she smokes or drinks. Does that questionnaire open a door for conversation? Most likely. What if the conversation looked different? What if the doctor was able to spend a little bit more time delving into that? What if the doctor took more time to offer support? Now, what if there was a quick screening at every doctor's visit? Kind of like the one when you take a child to the pediatrician and they do that lead paint screen. It's probably about 5, 6, maybe 10 questions. Does that open a door for conversation? And later we're going to be presenting a short workshop on screening, brief intervention, and referral to treatment, where we talk a lot more about this in depth, that we have to open those conversations. Medical providers have to be willing to take a minute or 2 minutes just to share information or ask some questions. Quite often, I know as a woman who goes into a number of doctors, you into your OBGYN, you're into your primary care doctor, they ask you all the time, are you depressed? Do you feel safe in your environment? But not at any of those appointments do they ask me if I have any issues or concerns with substance use. So again, it's getting those conversations, normalizing and making them part of our everyday lives in order to open those conversations and get that rolling.
I think mostly, Kathy, when we look at physicians, oftentimes we blame them for not doing things, only because in reality they're the entry point into the system. It's not necessarily their fault, and some of them have indeed been trained, but they have so many other systems that were specialized right now. Somebody is concerned with an OB/GYN problem, or somebody's concerned with cancer, somebody's concerned with liver problems. They're not looking at the person and say, well, what else is impacting on these systems? So even though we sometimes look at physicians as the problem, physicians are an entry point, and they're probably the initial step in the solution to the problem.
Mm-hmm. So what can we do? We can look at how we talk about a substance use disorder. Rather talk a positive urine specimen rather than a dirty specimen. That has completely different connotations. Say a positive with a person with a substance use disorder rather than an addict. Again, completely different connotations. When we talk about addiction as a disease, people start to see themselves as someone who is sick. It's really just about cleaning up our mouths and the way that we speak. And if people think about themselves as being sick, sick or ill people get better. Bad people don't always change. And so thinking of a substance use disorder as a moral issue, and that's a bad thing, doesn't give a lot of hope to those that are afflicted. So we need to learn about harm reduction and support it and vocalize our opinions as well. Harm reduction is just helping people live long enough that they can access treatment. Things like clean needles, Narcan, et cetera. But even these types of initiatives cause some to believe that we're just perpetuating the addiction. And that's not necessarily, of course, the case. But again, the stigma that falls around that is sometimes very clear. So we need to be patient with those receiving treatment as well.
I think one of the things that we started probably almost 20 years ago here, Kathy, is we didn't even know what the harm reduction model was, but part of our CBT approach was because I kind of understood that this was a chronic relapsing disease. Our theory on harm reduction model was decrease the volume, decrease the frequency, and increase the time between uses. And we could track that in a record so that people became positive about the fact that they could get better without necessarily being cured. So we did a lot of motivational interviewing and positive reinforcement to show them that they could make changes. And in one particular case that I can tell you about that related to the harm reduction model was a lady that I was working with. And I said, okay, you can drink one day, but you have to be off 2.
Yeah.
So we went from 1 day on, 2 days off. And she said, well, I didn't think I could do it. But then when I knew that I could drink on the 4th day, I was good to go. Well, then she got sick. So she drank for 1 day, missed 2, got sick on the day she was allowed to drink. Then all of a sudden she had 2 more days before she could drink again. Now she has 4 days of sobriety, which was the first time in 8 years that she had any sobriety. So when it came time to drink, she was unwilling to give up the 5-day string that she'd had for so many years. And as a result of using the harm reduction model, she's now almost a year and a half not using, and she's stable and healthy.
Yeah, that's a great story. That's a great story. All right. So John, talk about this just a little bit, if you don't mind.
Okay. John Kelly was the first big-time professor in addiction medicine at Harvard. And he knows, in terms of what he said, it can take up to 5 or 6 episodes of treatment to get one appreciable amount of recovery. Now, how he defines recovery, I'm not quite sure, but I think it has to do with more along the lines of not using at all. And so what he's saying is it can take 8 years of treatment to get one continuous use of 1 year of abstinence. I don't think that's a great outcome. But if you look at the definition of chronic relapsing disease, which the structure and function of the brain has changed, if I go 364 days and I don't use, and then I use the 1 day right now in the approach to treatment, well, I'm a failure because I didn't make it a year. I don't think making it a year, continuous year of abstinence, is a good record. That's now I've got 364 out of 365 days. I guarantee you my brain is better. I'm healthy. I did something right. So we need to continue to reinforce positive things that people are doing and not spend quite so much time at getting into the guilt and remorse that comes when I screwed up. So as you know here, we don't call it a relapse. Either you drank or you didn't drink, because we're trying to destigmatize the feelings that come with failure. I said, no, you just drank. So part of our component of what we're trying to educate our patients here is that no, it's not the stigma that's associated with you being a failure. We're just tracking the number of days you did drink versus the number of days you didn't drink. And in a particular case I mentioned just a minute ago, I said she was 1 day on, 2 days off. I said, well, that's 2 out of 3 is better than drinking 3 days in a row.
Right.
When people begin to grasp that they can get better, because oftentimes by the time they start seeking treatment, they've already given up hope. So part of our job is to instill a sense of hope, because together we are fighting the stigma that comes with all those derogatory terms that come with losers and people who are not going to make it. That just simply isn't true. And this is what he said is being authoritative with regards to your patient doesn't work. Being punitive doesn't work. Being kind doesn't work. Being empathic doesn't enable people to keep using. However, it does allow them to get into treatment. So I think that's a big part of what he was saying. And I think that's a component, as well as motivational interviewing. That's a component of what Carl Rogers was saying. I think you need to be empathic with the people that we're treating. I think you need to be extremely sensitive to their loved ones in terms of what's going on, because there's always a great deal of damage and fallout that occurs with people who have addiction issues. So the main thing is get people into treatment.
Mm-hmm. So, John, while we're working to change the narrative, because we have years and years of people with the perceptions of, it needs to be tough love. People need to hit rock bottom. I can't help because that's enabling. What do we do? What do we do in the meantime, until this narrative changes?
Well, my opinion is that you need to have more treatment facilities that involve the ability to patients to travel in and out of a continuum of care. You've got to be able to assess them quickly. Obviously, we'll be talking about that with regard to SBIRT. You need to get them assessed. You need to get them into, if you will, a sheltered, safe environment for short periods of time. 30 days is an arbitrary number. Sometimes people need to go for 3 to 5. I would rather some of my people go 5 days, 6 times, if insurance is paying for it, instead of one 30-day stint. Some people may need 60 days of treatment. I think what we have is an extremely expensive way to treat people now with regards to residential treatment. Obviously, it can be upwards of $2,000 a day for people to stay into care. I think we need to have better treatment outcomes as a result of treating people in some type of a unified, if you will, scientific approach to treatment when they go into residential care. But you have to have the people who assess the people, which is the physician who refer them to a clinician, whatever that is, that can treat them on an outpatient basis, manage their care, put them to an inpatient care, bring them back to that on outpatient care, and manage people for an extended period of time. Not 30 days. You have to manage people, as you know, for at least 2 years before you can teach them adequate coping strategies where they can do it. And at some point, they may need to go back to residential care for a short period of time. So if we destigmatize all the stuff that goes with people who are having treatment failures, or they're not doing what it is that we want, it's because we haven't fully comprehended all the subtleties that are necessary to bring about the change in the approach to addiction.
So what can we do? As John had said, spend those allocated funds for substance use disorders on treatment as much as possible. Develop and widely disseminate mental health protocols, making them part of every medical exam, and put multiple addiction courses in every medical program. Now, of course, this is just the icing on top of the cake. There's so much work to be done, to stop stigma surrounding substance use disorders. So, John, comments here as we close with our viewers at all in regards to stigma?
Yeah, I think, like most people know with anything else, if somebody is not like me or doesn't look like me, walk like me, talk my way, I can figure out a way to make them not fit in. I think the hard thing to do, especially when we're talking about mental illness and substance abuse problems, are when people are in a group of people talking about it, and oftentimes people are making fun of someone who has an addiction. Someone has to speak up and say, that's not right. So I think you're going to be going against the stream, if you will, of conventional wisdom. I think we have to be bold enough to actually state what we believe to be true, which is people get better as we improve the quality of care for people and the better outcomes. Hopefully, some of that stigma will lessen. I think the community education efforts that SIF is doing, and all the people that are associated with what's going at SLU, all that stuff is extremely important. The more councils we have to discuss this increases the number of people that are aware of what's going on.
Most definitely. Thank you, John, for today's presentation. Now, I'm going to see if I can pull up one more little video to just kind of close us here. And then after that, we'll talk a little bit about how you can earn some CEUs for participating today. So let's see what I can do here about sharing the screen. Here we go. Okay, another great video, I think, really. So what we're hoping here, guys, is that you will take what you've learned today, and hopefully we've opened your eyes a little bit to the stigma associated with the substance use disorder. We are offering CEU credit for you through St. Louis University. So in order to receive that credit, participating in today's workshop, you'll need to complete the following. And we're going to email that to Carissa Vandenberg Clark. She is the Assistant Professor for Family and Community Medicine at St. Louis University. And I've given you her email down there, right below. We're asking you to write a 2-page reflection paper on how your thinking has changed after watching this digital presentation. You know, what attitudes have changed, what practices will change, and then cite some evidence from the presentation throughout your reflection paper. And then if you can, please put in the subject line of that email, CEU request for stigma and its devastating consequences. And that way, Carissa will know what it is that she's giving you that CEU credit for. So again, thank you very much for attending today, and we hope that you'll visit some of our other presentations. Thanks, John.
Thanks, Kathy.